So good afternoon, everyone, and welcome to Medical Grand Rounds. Before we get started, I would just like to make a brief land acknowledgement. McGill University is on land which has long served as a site of meeting and exchange amongst Indigenous peoples. We acknowledge and thank the diverse Indigenous peoples whose presence marks this territory on which peoples of the world now gather. Just a brief reminder to please enter your questions at the end of the presentation. Please enter them in the chat as well. Please just remember to fill out a brief survey that will be sent to you right after the Medical Grand Rounds presentation. We're very fortunate to have a visiting professor today, courtesy of the Division of Nephrology, and I would like to ask my colleague, Dr. Thomas Mavrokanis, to introduce our speaker today. Thomas, the floor is yours.
Thank you very much, Nadia. So it's a pleasure for me to introduce today Dr. David Charytan. Dr. Charytan is the Norman Wikler Professor of Medicine at New York University Grossman School of Medicine, and he's also the Chief of Nephrology Division at NYU Langone Health. He obtained his MD degree by New York University, did his residency at Beth Israel Medical Center and his fellowship at the Brigham and Women's Hospital, both at Harvard Medical School. He was Associate Professor of Medicine at Harvard before moving to NYU in 2018. Dr. Charytan is investigating the pathogenesis and treatment of complications of CKD and end-stage kidney disease, with a focus on diabetic kidney disease and cardiovascular disease in the setting of chronic kidney disease. He has been the PI of 8 NIH grants and has helped lead multiple clinical trials as member of the executive leadership team. He has authored more than 190 manuscripts in high-impact journals, including the New England Journal, Circulation, JASN, and Kidney International. He's also an associate editor of the CJASN. So, David, we're very happy to have you at McGill Grand Rounds, and the floor is yours.
Okay. Thank you very much for the invitation and the introduction. I only wish it were in person. I've had good experiences the few times I've been up in Montreal. Although I have rooting interests against your hockey team. But all right, just a brief, as someone who spent many years in Boston, but briefly, here are my disclosures, and I think just in terms of the relevant ones, they include Medtronic, which funded some of the work that I will review in this, and Janssen Pharmaceuticals, which also was involved in funding some of the work that I will discuss. Okay, so I'll start just with a quick case. Just to sort of center us, a 65-year-old male referred for evaluation with an eGFR of 25 ml per minute that's been decreasing by a couple of ml per minute per year, and has a past medical history notable for diabetes, hypertension, myocardial infarction, and class 2 heart failure, as well as a prior cholecystectomy. And the medications currently include glargine, atenolol, and lisinopril, with an exam notable for blood pressure 140/90, currently clear lungs without edema, and then you can see slightly elevated LDL and a creatinine of 2.4, as well as low hemoglobin and moderate levels of ferritin. And just to set the stage, I want to ask people to think about, what treatments should we consider for this patient based on the available evidence. And I suppose as a learning objective, I would point out that I'm going to go through, why this patient is at risk. Number 2, how is this patient different than patients with preserved kidney function who have heart failure or at risk for heart failure? And then lastly, what's the evidence base for treatment in this population and the dialysis population with more severe CKD for these diseases? So a bit of background, these are 2 landmark studies going back to 2004. On the left side, in the study by Go, this is data from a large EMR system in Northern California. And as you can see, quite nicely illustrated that as you went from a GFR greater than 60 ml per minute to stage 5 CKD with a GFR less than 15, there's really an enormous increase in the risk of cardiovascular events in this population, an almost 20-fold increase in risk. And on the right-hand study, this was a secondary analysis of a post-MI clinical trial. And you can see again quite nicely as you go on the left to right in each set of bar plots, quite dramatic increases in the risk of subsequent cardiovascular events, death from cardiovascular causes, heart failure, resuscitation or sudden death as GFR declines, with markedly increased risks when you get down to advanced CKD. And I'll point out that these sort of taupe colored bars just point out a GFR less than 45 ml per minute. So just moderate CKD and still these enormous increases in risk. And as the years have gone on, we've refined these estimates. And as you can see here from the CKD Prognosis Consortium, so this puts together data from hundreds of thousands of patients in various cohorts. And you can see going from right to left on the x-axis that as GFR declines, there are dramatic increases on the right-hand panels in cardiovascular risk. And you can see, the lowest levels of GFR, 8-fold increases in risk. And also as you go on the different colored lines, as ACR, albumin to creatinine ratio, another indicator of renal damage, marked increases in the risk of cardiovascular mortality. And in fact, while as nephrologists, we tend to focus on the risk of progression to dialysis, and that what patients are interested in when they come to see us. As you can see here in registry data, the risk of actually cardiovascular death for the majority of patients that we see with kidney disease, particularly those with diabetes, markedly outweighs the risk of progression to end-stage kidney disease when these patients make it into the hands of nephrology. So really, it's quite an enormous problem. Looking at, what are the causes of death, on the left-hand side here, I'm showing you data from the United States Renal Data System. And as you can see, so this is a registry of all dialysis patients in the United States. And as you can see, this is sometimes referred to as the pie chart of death. And as you can see, the biggest slice of the pie is actually arrhythmic death, as shown here. And then a fair number of patients are dying from heart failure. And remember, in this orange color, and as I pointed out earlier, the risk of the absolute event rates, not just the proportion accounted for by these, are markedly increased in this population compared to those with preserved kidney function, as much as 20-fold higher, depending on age. And shown on the right is some work that we did just to show you that this risk of sudden death is not just in the dialysis population. This is data from TREAT, which was a study of patients with diabetes, CKD, and anemia. It was an ARNIs study. And as you can see, again, both for PCR going from front to back and GFR going from right to left, marked increase in the risk of sudden death as GFR declines. And this has been shown in a variety of studies. And when you look at, again, dialysis data from the US, you can see, again, while overall cardiovascular mortality has been coming down in this population, that sudden cardiovascular death remains an enormous problem, accounting for a very high proportion of death. And then shown in this brown color in the bottom panel, heart failure continues to account for a very high proportion of events in this population. And in fact, just to put that into context for you, this is a figure from a conference paper, but you can see that the dialysis population has a higher risk of sudden death than any other population, including advanced heart failure patients who had sudden death at a rate of about 4% a year. compared to the dialysis patients who have an average rate of about 5% a year, but even higher in the first year. And even in non-dialysis CKD, you can see markedly higher than the risk in the general population, by an order of magnitude or more. And then turning to heart failure, you can see here registry data from the United States Renal Data System, which also, at least for Medicare patients, provides data on pre-dialysis CKD. And you can see that the cumulative probability of a heart failure event, is much higher in the hemodialysis population. But you can see in this blue plot that over the course of 3 years, roughly 40% of pre-dialysis patients will be admitted for heart failure. So it's quite an enormous rate. And in fact, when we look at the prevalence of disease in the CKD population compared to the non-CKD population, again, using USRDS data, you can see that compared to the non-CKD population, a much higher proportion is shown here of the CKD population, at least in the elderly. This is Medicare data. So for those not familiar with US data, you're entitled to Medicare above the age of 65 or with disability. But 40% will have prevalent CVD. And the largest proportion of that is made up by heart failure, with roughly 28% of patients having heart failure. Looking at the bottom, you can see that this risk goes up in the various colors with more severe CKD stages in this light blue. And you can see this risk rises as GFR declines. So much more heart failure in the stage 4 and 5 patients, again, about 40 to 50% of patients. And then in terms of what happens to these patients, you can see that the overall risk of heart failure hospitalizations is quite high, rising with both lower GFR or higher ACR shown in these two different bars. And you can see the risk multiplies if both are bad. And as you can see here, about 5.8 hospitalizations per 100 patient years for heart failure in this population. And more than 35 days per 100 patient years in the hospital. So it's an enormous problem for our patients. And moreover, as shown here again, USRDS data, what happens to these patients when they're admitted for heart failure? It's not just discharge and go home with treatment, but you can see while many patients in the blue panel are discharged alive, quite a few get readmitted and die on a subsequent hospitalization, or die in the gray on the initial admission. And as shown here on the right, there is markedly increased mortality from these heart failure admissions as GFR declines. So in the green CKD stages 4 and 5, as you can see here on the right, by 24 months, roughly 60 to 70% of your advanced CKD patients with a heart failure admission are no longer alive. So it is quite the problem for this patient population. So the question that I'll turn to in the rest of the talk is, how should we treat these patients and what's the evidence base? And this is work I did way back during the research years of my fellowship and the early faculty, and just looking at how, the cardiovascular treatment paradigms are to the credit of the cardiologists, based on many quite large clinical trials that really have provided great evidence for the treatment of cardiovascular disease. And nephrology suffers from a lot of expert opinion and not quite the same level of data, though we're trying to catch up. But as you can see, when we looked at cardiovascular trials with at least 1,000 patients, the vast majority explicitly excluded patients with end-stage renal disease or advanced CKD, while not excluding patients with other risk factors. And as shown on the right-hand panel, as GFR is rarely described for those who actually happen to make it into the trial. So, end-stage renal disease patients, for example, are rarely going to be included, even if the explicit criteria don't include them. So our evidence base, at least, probably doesn't include a lot of of advanced CKD patients. Well, should it apply and be extrapolated nevertheless? And I think that's where we start to get into the next part of the talk, where I'll just talk about some of the differences in the pathophysiology of cardiovascular disease, in particular heart failure and arrhythmia in our patient population. And as I'm showing you schematically here, there are really significant differences in either the kinds of factors that contribute to heart failure and arrhythmia in the CKD population, or their importance. So factors that contribute include pressure and volume overload, which may induce secondary changes in myocardial structure, ischemic CAD, which may result in scar, uremic factors, and they don't have time to list all of them, but just a few of circulating factors and metabolites that are altered in CKD are included here. And then for patients on dialysis, dialytic factors that may cause further injury to the heart. And then, of course, all this happens on a background of more standard risk factors like diabetes and atherosclerosis. And all of those contribute to myocyte hypertrophy, interstitial fibrosis, capillary rarefaction, and then ultimately systolic dysfunction, diastolic dysfunction, and as well as arrhythmia. So I'll take you through just a few of these briefly. What happens to the heart in CKD? Looking echocardiographically, this is nice data from the chronic renal insufficiency study. And as you can see, LVH is quite common. 70% of patients in this study of patients with pre-dialysis GFR less than 60, with and without diabetes, and 70% of the patients in this research study had LVH with moderate CKD that rises a little bit, although not significantly different by the time patients reach end-stage kidney disease. But pump function, as measured by ejection fraction, tends to decline over time. In another study, this was from a registry from Korea, you can see that both concentric and eccentric remodeling are markedly increased with mild CKD, but in this study, you can see a slightly higher rate in the advanced CKD population. But I think the bottom line here is that by the time you reach moderate to severe CKD, even before dialysis, LVH is nearly universal, and then reduced ejection fraction becomes more common with time spent in late-stage CKD and dialysis. And why is that? I talked about capillary rarefaction and myocardial fibrosis. You can see here, this is an autopsy study of end-stage renal disease patients, and you can see in the uremic heart on the right, compared to the normal heart on the left, that there's significant dropout in myocardial capillaries and some hypertrophy of myocytes, so that heart rate goes up, and the myocardial capillary to myocyte ratio decreases markedly, presumably causing a propensity towards ischemia and therefore arrhythmia in this population. And when we looked in more moderate CKD patients as well as dialysis patients in another autopsy study, you can see quite dramatically how fibrosis increases in the hearts of patients with mild CKD here on the right, or I should say moderate, and then is really dramatically increased in the dialysis dependent population, and accompanied by that same dropout of capillaries and an increase in the myocyte to capillary distances as GFR declines. And we can detect that as a significant risk factor with clinical tools using a myocardial PET, which can measure absolute blood flow and also reserve blood flow, so what you can do in response to stress or vasodilation. And it's felt to be a relatively good marker of capillary and small vessel perfusion and supply. And as you can see here in this study from Brigham and Women's, we found in our PET registry that shown here, the coronary flow reserve or that index of capillary supply dropped off markedly in late stage CKD. although not significantly different between the late stage CKD and the dialysis patients. And then this was an independent relationship. And when you looked at it, how did this correlate with the risk of death? You can see that the lower the coronary flow reserve was, 1.5 is often considered an index of normal. The vast majority of advanced CKD patients were below that number and is markedly associated with increased risk of cardiovascular death. And looking at it versus more traditional markers of ischemia burden, which is shown in the different bar plots here, 0%, 1 to 9%, or greater than 10%. At any level, the risk was increased with a lower flow reserve. And this really was actually a more important predictor than the ischemic burden itself. Other factors that are involved, just to show you another example of a unique uremic factor. This is looking at clotho in the heart of patients with and without CKD. And so we took myocardial samples from patients with moderate CKD or without CKD. And clotho is a cofactor for FGF23, whose primary role is in phosphate metabolism, but has felt to have a role in cardiovascular disease as well. It's a cofactor, but also an anti-aging hormone. As you can see, clotho expression in the hearts of patients with CKD went down dramatically as GFR declined. When we looked at fibrosis in these myocardial samples, clotho seemed to have this anti-fibrotic relationship with more fibrosis, the lower clotho was. And then when we looked at cultured cells, as if you knock out clotho, you get an increase in expression in cultured myocytes and fibroblasts, also of the collagen and other markers of fibrosis. So another unique factor that we don't think would be disturbed in patients with preserved kidney function, which again raises the question of whether we can truly extend the evidence base from other populations to this population. Inflammation is another factor that's been implicated in cardiovascular disease in general, but seems to have an outsized role in kidney disease. So on the top panel, this is a study, interestingly, of patients with and without kidney disease and with and without exposure to TB. But I think it, despite the TB angle, nicely illustrates how many different factors, inflammatory markers and circulating cytokines are increased in the kidney disease population compared to the non-kidney disease population, shown in a table from a different study. On the bottom panel, you can see all of these different markers are increased quite dramatically in kidney disease patients compared to controls. And most interestingly, when you look at these as a marker for risk of death, and yet another study, not only is IL-6, one of the prototypical pro-inflammatory hormones, associated with an increased risk of death at higher levels in cardiovascular death in the CKD population, but actually SNPs that are associated with higher levels are also associated with increased risk of death and cardiovascular death, suggesting that based on this Mendelian randomization, that this is causal and not just associative. Lastly, I want to just briefly touch on the topic of dialytic injury in this population. So this is a meta-analysis of implantable loop recorder studies, which we used to follow patients on dialysis and assess how often arrhythmia is happening. And I just want to point out, that the risk of atrial fibrillation in these patients on dialysis, at least subclinical atrial fibrillation, is quite enormous. In this population, about 20% of patients per year of follow-up are having at least loop recorder detectable incidents of AFib. When we looked in this in our study, and not just in the meta-analysis of all the available studies, you can see that 41% of patients, as shown here, had atrial fibrillation detected during a 6-month monitoring period. And as you can see here, the number of days out of 180 days of monitoring in some patients was quite enormous. There's a very high, it's not just AF is occurring, but it's occurring with a high burden. Shown on the bottom, you can see that the number of minutes per day in AF is often quite high as well. So there's a high incidence and a high burden of atrial fibrillation in many of these patients. And I bring that up because this may be causing a tachycardia-induced cardiomyopathy that's not an issue in other populations. And furthermore, for the patients on dialysis, while it keeps patients alive, I think it's become very clear over the years that it is not a physiologic treatment. So we often like to refer to the dysphysiology of dialysis. So this is registry data on the left. And I just want to point out that the pattern of deaths, and particularly of cardiovascular causes and cardiovascular hospitalizations, neatly mirrors the dialysis treatments that we give the patient. So that you can see here shown quite nicely that as we dialyze patients on hemodialysis treatment 1 of the week, the rate of cardiovascular death and hospitalizations increases in arrhythmia, and then smaller peaks on the subsequent HD2 and HD3, the second and third treatments of the week. And then similarly, in a study of the single dialysis unit and looking at sudden cardiovascular deaths, you can see that the risk of death and sudden cardiovascular death increased with the number of hours from the last dialysis treatment, peaking at the end of that long weekend interval, the way we typically do dialysis. So bottom line, our patients are at quite high risk, and some of what we're doing to them on dialysis is actually causing that. And I spoke about AFib and possible tachycardia-induced myopathy. And again, in our study with the loop recorders, you can see that on hemodialysis treatment 1, 2, and 3 of the week, there's this enormous peak of atrial fibrillation events. So that while we're keeping patients alive with our dialysis treatment, this may be a very important factor in why so many of them end up suffering from heart failure and death. And there may be a need to treat this if we want to prevent heart failure events and sudden death in the long run. Furthermore, Chris McIntyre's group, formerly from the UK, but now a little west of you in Canada, has done some very nice work to show that there appears to be myocardial ischemia during dialysis. So they actually did here intradialytic PET scans of the heart to look at myocardial blood flow. You can see it drops quite dramatically during dialysis in a non-anatomic manner, suggesting this is a small vessel phenomenon. But moreover, these drops in perfusion matched with areas of reversible wall motion abnormalities that occur during dialysis and are hypothesized to cause repetitive cardiac injury with each treatment that may lead to loss of ejection fraction over time. And then lastly, on this background of everything else we're doing to these patients, I want to point out that we take patients who are hyperkalemic, and when we looked at in the modern dialysis study, what happens to electrolytes on dialysis, you can see here that you start out with a high potassium, about 5 pre-dialysis, but that drops down to normal, and in many patients subnormal by the end of dialysis. And bicarbonate goes from subnormal to sometimes supranormal and alkalotic post-dialysis, and similar changes in magnesium and phosphorus, all of which, and calcium, all of which could increase propensity for sudden cardiovascular events around the time of dialysis. And do we need to address this in order to do better by our patients? Lastly, I just want to point out that when we talk about heart failure in the advanced CKD population, particularly the dialysis population, we may need to reconsider our definition. So the consensus definition of heart failure is that it's a clinical syndrome with typical symptoms like shortness of breath, lower extremity edema, and so forth. You can have typical signs like crackles on exam and peripheral edema, and usually have structural or functional heart abnormalities, and we can subcategorize that as with or without a reduced ejection fraction. And then we additionally categorize these according to the severity of symptoms. These are the typical NYHA grading scale, and you can see it goes from no limitation in class 1 to severe limitation of activity in class 4. The problem is when we're talking about our dialysis population, a lot of these definitions are questionable utility because we can get accumulation of fluid with a normal heart entirely on the basis of renal function or lack of renal function. And you may have primarily functional problems related to the kidney rather than structural heart problems. So this definition is often of questionable use. Turning to the most recent AHA guidelines about heart failure, they further classify heart failure into those who are at risk of heart failure. Without current signs, but at risk due to comorbid conditions, which interestingly, they didn't actually explicitly include CKD on this. Stage B is pre-heart failure without current signs and symptoms, but with evidence of structural heart disease. And I would posit to you that based on the evidence I've shown you so far, that most kidney disease patients are going to fit into this ballpark or further to the right on this. And then, of course, we get into stage C, symptomatic and advanced heart failure. I'll just point out that given the issues that I discussed a moment ago, that new definitions have been posed for those who are on dialysis that sort of mirror the standard definitions of dialysis, but add in whether these respond simply to fluid removal with ultrafiltration and really looking specifically at whether there are structural abnormalities of the heart or whether this is really purely a phenomenon of lack of renal function and ability to clear fluid. So, for example, you wouldn't want to characterize something as a heart failure event if someone just simply skips dialysis for a week and winds up having dyspnea that's responsive to fluid overload. So having set that background, I'd like to spend the next part of the talk discussing about our treatment paradigms and how we should think about treating these patients and what the best evidence is. So I'm showing you here from the most recent heart failure guidelines from the AHA, what the suggested treatments for heart disease in the setting of CKD are. And you can see for those at risk, there's a suggestion of controlling blood pressure using SGLT2 inhibitors, and then a variety of other suggestions. And then once patients actually have structural abnormalities, adding in angiotensin receptor or converting enzyme blockade, beta blockers, use of an ICD. And then for patients who actually have actual heart failure and are not just at risk, they add in angiotensin receptor neprilysin inhibitors, beta blockers, mineralocorticoid receptors, as well as the SGLT2s I mentioned earlier, and ICD treatment, as well as some specific therapies with various risk factors. So I'd like to go through each of those recommendations and how that evidence applies in the CKD population. So let's talk about optimal blood pressure in the setting of advanced CKD and dialysis, and what do we know and how do we apply that? As you can guess from the X, I have questions about whether we can really apply that, at least for patients in dialysis. So shown in the top panel is a study that compared ambulatory BP to the blood pressure measures that we get in dialysis. And as opposed to the general population, for patients in dialysis, we routinely measure dialysis before blood pressure before hemodialysis, after hemodialysis, at least 3 times a week. We also often get a standing or sitting blood pressure well before we hook them up to the machine, and then multiple, usually every 15 minutes or half hour during the dialysis treatment blood pressure. So there's one question about which of those blood pressures counts when you want to manage blood pressure, which is really not an issue for the general population. But moreover, there's also blood pressures in non-dialysis days. And when you look at the comparison of the pre-dialysis blood pressures or the post-dialysis blood pressures, regardless of whether it's systolic or diastolic, what this shows quite nicely is those pre-dialysis measurements, which we're often treating to, really are very poorly correlated with ambulatory blood pressures. But most of the time, we end up using as a treatment target the pre-dialysis blood pressure. Moreover, we have a particular pickle with patients on dialysis where we try to treat blood pressure in that patients come to dialysis a few times a week. We need to remove 2 to 4 liters of fluid for every treatment that a patient on hemodialysis, if we're doing 3 times a week, shows up. But we can cause hypovolemia by removing 3 or 4 liters over a couple of hours. And that's associated with frank hypotension, feelings of syncope or pre-syncope, end-organ ischemia, hypotension, access thrombosis, cramping, fatigue that limit our ability to do that. Conversely, if we allow patients to be hypervolemic, they may have worse blood pressure, edema, and fatigue. Again, while these issues are not uncommon to other patients with heart failure or risk of heart failure, they're vastly exaggerated in the importance for the end-stage kidney disease population. And moreover, there's been a very strong association of drops in blood pressure during dialysis, which average about 28 to 40 millimeters over that 3 to 4 hour treatment, at least for systolic blood pressures. And there's strong associations with the risk of cardiovascular and all-cause mortality. And moreover, there's very little hypertension treatment data in the dialysis population in terms of large randomized trials like we have in the general population. But one nice study from just a few years ago, and that gives you a clue of the state of the data, that we're still doing general blood pressure studies that are still pretty small in the dialysis population in the year 2018, but that's the state of data. So in this study, they randomized just 126 patients to either a standard blood pressure, which was 150 to 165, 155 to 165 pre-dialysis versus a target of 115 to 140. So not particularly tight control, but you can see there was a very significant change in the blood pressure, although mean blood pressure is only about 140 pre-dialysis in the tight arm. But importantly, the study was stopped early because of the signal of an increased risk in the tighter control group, so that the risk of hospitalization went up about 65%. In the tight hospitalization group, there was a 2.8-fold increase in the risk of vascular access thrombosis, and smaller risk increase that were non-significant in the risk of cardiovascular death was consistent with that signal. So really not clear how we should treat blood pressure in this population. All right, so what about SGLT2s in this population? Showing you here is meta-analytic data from SGLT2 studies broken down by GFR categories. I'm sorry, it's a little bit small in this slide, but going from top to bottom with a GFR greater than 90 down to 30, I think the take-home point is that the relative risk reduction was for prevention of events seems to be very well preserved down to a GFR less than 30 in this patient population, as shown on the right-hand slide. When we as GFR declines, the relative risk reduction actually seems to potentially be improved. And certainly, as we looked here in data from the Credence study, when you look at cardiorenal composite or a heart failure endpoint, there was a marked improvement in absolute risk reduction because the event rate is so high as GFR declines. So small numbers of patients in these GFR categories, but at least a signal for preserved or better efficacy at event reduction as GFR declines. And in fact, it is important to bear in mind that these drugs were initially designed to lower the glucose, and that effect at least is markedly reduced as GFR declines. So you can see here in the stage 3B CKD patients, as GFR declines, you really have a very minimal at 13 weeks reduction in A1C, but yet when we do a mediation analysis, you can see that these drugs seem to have a signal of preserved benefit even when they don't have much glycemic lowering efficacy, suggesting that they're doing a lot more than glycemic lowering in terms of their cardiovascular benefits. So you can see here, just looking at the primary composite, the cardiovascular and heart failure composite, there's really no difference when you account for glycemic lowering or not in terms of their clinical efficacy. Unfortunately, there's no data right now about what to do when patients reach really late-stage CKD and dialysis. We recently received in DAPA CKD, they did actually continue, or sorry, EMPA kidney, they did continue the use of empagliflozin in that study once patients started on dialysis. So there's been no report of safety signals, so it's probably safe. But we recently received an award to do a pilot study of the use of empagliflozin in new dialysis patients. So hopefully some data coming in the not too distant future. But right now, really not clear what to do. So what about ACE and ARB? So most trials, we use these widely in our CKD population to prevent progression of CKD and cardiovascular events, but most of these trials are actually excluded the very advanced CKD population. So what to do for these patients? There is a little bit of data. So this is a small study that looked at benazepril in patients with advanced CKD, as shown here. And you can see group 1 and 2 were the advanced CKD population. And you can see that even in the very advanced CKD patients who you might be afraid of using an ACE inhibitor or an A or B, there was a suggestion of a real benefit for prevention of end-stage renal disease or cardiovascular events, even at very low levels of GFR. And this corresponds with the recent STOP ACE study, which suggested that there's at least no benefit to stopping these drugs in late-stage CKD, and at least a suggestion of potentially some risk. In the setting of dialysis, the data is a little less clear. So there are a couple of studies now. The Pathophysiology trial was a roughly 400-patient study in patients on dialysis. And as you can see here, really no convincing signal of a benefit, although the cardiovascular event rate was lower than they had anticipated in designing the study. There was an open label study in contrast that showed quite a significant reduction in risk, and the telmisartan study, another fairly sizable study for dialysis, comparing telmisartan and placebo. And you can see again, heart failure admissions were dramatically reduced in this study, as were cardiovascular deaths, shown on these two lines here. So at least a suggestion that we should be continuing these agents in advanced CKD. What about beta blockers? Here we have some pretty good evidence. I point out, again, reasons to think about whether these apply to our patients is that a lot of these drugs are renally metabolized, and more of them can be dialyzed off. So atenolol and metoprolol, as opposed to carvedilol, bisoprolol, and so forth, are removed during a dialysis session, and that might affect their efficacy. But as shown in the subgroup analyses of the CBIS-2 trial and the MERIT heart failure trial, which MERIT was with metoprolol, and CBIS, I think, was bisoprolol. But you can see at least at GFR less than 45 ml per minute, there was preserved efficacy or even better efficacy at preventing cardiovascular events in these heart failure populations. In contrast, when we looked at the carvedilol trials that established the benefit of these drugs in heart failure patients with reduced ejection fraction, you can see that efficacy was pretty well preserved in early CKD, but while the interaction p-value was non-significant, there is certainly a suggestion of a loss of benefit in the advanced CKD population. There is some data on dialysis patients. This is a nice study, a randomized study comparing lisinopril versus atenolol in patients on hemodialysis. And again, a study that was stopped early because the patients receiving beta blockers, in this case atenolol, did significantly better than the lisinopril patients. You can see that adverse event rates were markedly increased with lisinopril versus atenolol. And going down the rows, you can see here, an even stronger signal when you start to look at the cardiovascular events. So a fairly strong signal from this that beta blockers, at least if you have to choose, may be preferred over ACE inhibitors once patients start in dialysis. And in fact, there's an oft-quoted study looking at the use of carvedilol for patients with cardiomyopathy on dialysis, so reduced ejection fraction patients. And while this was primarily designed to look at echocardiographic function over time, there was quite striking reduction in mortality and cardiovascular mortality in particular, as well as sudden death in particular, nearly 70% reduction in cardiovascular deaths, perhaps a little bit unbelievable in terms of effect size, but consistent perhaps with the study I just showed you earlier. How about ICDs? So another area where I think we need to think twice. So we looked at this using USRDS data that I told you about before. And I think this is registry data, so not randomized data. But two things I want you to take home from this is, one, many of our patients on dialysis have catheters and are at risk of infections, which can be quite problematic in patients with an implantable defibrillator, especially in these days when only the intravascular lead, as opposed to the epicardial leads, were available. But the take-home point here is, in addition to almost 988 infections per 1,000 patient years in this population, and bacteremia occurred at a rate of nearly 1 in 2, or roughly 1 in 2 patients, and not insignificant rates, so not surprisingly, of device infection. When we looked at secondary prevention, you could see there was a small suggestion of a benefit, but it totally attenuated by 2 years in this population with the super high mortality rate. And there's been one randomized trial that was stopped early due to poor efficacy. They excluded patients with ejection fractions under 35% in this dialysis study, but you can see absolutely no suggestion of a benefit in this population. So again, I think we have to think twice about using these devices for primary prevention in patients on dialysis or near dialysis. What about our patients with symptomatic heart failure? So I went through a lot of these treatments already, so I'm not going to go through each of those again, but how about ARNIs, angiotensin neprilysin inhibitors? Unfortunately, at this time, there's no RCT data that's been sub-analyzed to look at the cardiovascular benefits of these agents in the late-stage CKD population. There are a number of real-world data analyses that do suggest there's a preserved benefit with at least moderate stage 3 or 4 CKD. And the only RCT evidence I know that's looked at this looked at only the renal benefits, which might give you a reason to use them, and showed with this agent, sacubitril valsartan, in a preserved ejection fraction population, that there was a lowering of the risk of CKD progression, and that's consistent with some of the registry data. So, and Dr. McCausland, who's the first author on this, currently has a pilot study in the dialysis population that's recruiting to look at this question. But so no good evidence there. What about MRAs? This is a subject close to my heart. Lots of reasons to think about MRAs in the advanced CKD population. And in particular, in addition to any effect directly on NAK ATPase and sodium retention, spironolactone probably has these additional effects in advanced CKD population. So maribuphagenin is a digitalis-like substance that accumulates in late-stage CKD and has been associated with cardiovascular outcomes, particularly in animal models. And importantly, giving spironolactone, at least in experimental models, as shown here, can attenuate maribuphagenin-induced cardiac fibrosis or nephrectomy-associated fibrosis, as shown here, and really dramatic reductions in collagen. Additionally, in models of deoxycortisone salt-induced injury to the heart and kidneys, just talking about why you might use spironolactone. I see I'm running out of time, so I'll try to hurry it up. The take-home point here is that mineralocorticoid receptors, independent of the salt reduction, were important in the cardiovascular sequela of this model, but not the renal sequela, suggesting spironolactone might be a benefit. And spironolactone also, or aldosterone, may have effects independent of the aldosterone receptor that are non-genomic on the estrogen receptor and epidermal growth factor receptor that lead to fibrosis and oxidative stress independent of the salt retention. There is some data here. So there have been a number of landmark trials suggesting a profound benefits in the setting of reduced ejection fraction of heart failure, but less impressive benefits that were non-significant overall in those with preserved ejection heart failure. Two landmark trials recently that suggested significant benefits to Finerenone and non-steroidal mineralocorticoid receptor antagonists in late-stage CKD. Although I'll point out the second of these studies excluded patients with overt heart failure, but really significant reductions in the CKD populations down to about stage 4 in reduction of risk. And benefits that seem preserved, although maybe a suggestion of some attenuation of benefit in very late stage CKD is shown on the left-hand side of these plots. Use in late stage CKD, though, is a dual-edged sword. While you might want to use these for myocardial fibrosis reduction and preventing arrhythmic, and maybe in patients who have preserved kidney function to some extent and still make urine for an antihypertensive effect, hyperkalemia, gynecomastia and the fact that they don't seem to have a benefit in reduced ejection heart failure are concerns. A Canadian study did show that the Finerenone was safe in short-term use, although there was some increase in hyperkalemia in the dialysis population. And there's been one sizable outcome study from Japan comparing spironolactone to placebo. And you can see these rather large benefits on cardiovascular death, a 60% reduction, and all-cause mortality, 65% reduction. That seems a little bit unbelievable, and maybe a small trial effect. And there was quite a high dropout rate in these studies, raising some questions about the validity, but still quite impressive effects. But unfortunately, in some other smaller studies, spironolactone versus placebo for 40 weeks using MRI to look at cardiovascular effects, there was no benefit at all on cardiovascular function, LVMI by MRI, minimal effects on blood pressure, and real increase despite the protocol in hyperkalemia. And similarly, when we looked at this with 3 different doses of spironolactone to placebo, no benefit on LVH, although some suggestion of a benefit on myocardial blood flow. And again, despite a very tight protocol, there were increases in the risk of hyperkalemia, suggesting that you at least need to follow these patients quite carefully before using it. There are 2 large ongoing RCTs that hopefully will provide some more definitive data in the coming years. Lastly, just for the last minute, anti-inflammatory therapy is shown here for canakinumab in generalized atherosclerotic disease, not CKD, has caught on in recent years, although not quite prime time. People have looked at this in the setting of CKD despite infections. So this is an anti-IL-6 blocker, and you can see in this dialysis study marked reductions in inflammatory markers in this population. But this company has abandoned the dialysis indication because there were signals for an increased risk, and not shown in the slide, increased cardiovascular deaths, although they are pursuing the CKD population that had similar findings in their study. We looked at anakinra, which is an IL-1 blocker, found that it was quite safe in a dialysis population lasting about 6 months. And no increase in SAEs, and IL-6 levels decreased quite dramatically in this population, and at least on treatment CRP also decreased. So 2 ongoing studies looking at this that may provide definitive answers, both targeting IL-6. And lastly, just in the last minute, I want to talk about dialytic injury. So this is a study that I did with Pat Pun, looking at whether we could reduce the change in potassium levels and causing hypokalemia or hyperkalemia with various interventions to reduce the risk of arrhythmias during dialysis. Just a pilot study, but I think conceptually this is something that we may need to consider is Instead of prescribing dialysis with a single potassium removal strategy for an entire month based on a single measurement at the beginning of the month, which is what we do in outpatient dialysis in most places, taking a more precision-guided approach to reduce this kind of injury or myocardial stunning injury with tailored ultrafiltration. So that may be something coming in the future. A lot of data to review there, but I would just say that our population is characterized by enormous rates of cardiovascular morbidity and mortality that are really higher than in any other population you might see. The pathophysiology is distinct, and our patients were excluded from other trials and metabolize drugs differently than other patients. So we really can't directly extend the standard of care from other populations to the late stage CKD population. But I'd say at the current time, probably the best evidence, if you have a late stage CKD patient or a dialysis patient at risk for heart failure or with frank heart failure, is that beta blockade and use of MRAs is probably the most evidence-guided approach, and you need to really think through carefully other approaches. So sorry I went a little bit long, but we hopefully have a few minutes left for questions.
Fantastic. Thank you so much for this excellent lecture and comprehensive overview. A very complicated topic. At some point, I'd like Thomas to say a few words about the Decide CV clinic, which brings the cardiologists, nephrologists, and endocrinologists together. This is happening here at the MUHC. I have a question for you. Obviously, spironolactone, we all recognize the benefits. Do you think that we'll be studying the combination of spironolactone in heart failure with these sodium, zirconium, cyclosalate, or patiromer kind of medication? So, should we give a medication and then give a medication to counteract, one of the effects of? I'd like your thoughts on that.
Yeah, so I'll give you two thoughts there. I think one is that that company is already pursuing that, in terms of ACE inhibitors and ARBs in the pre-dialysis population. And I think the answer is probably yes, although the risk is always that the more medications we add on to these patients, and polypharmacy is a real issue in these patients, is that compliance may go down or adherence. And you might get hyperkalemia anyway, or less efficacy because patients don't use the drugs. I think in the dialysis population, the answer may be yes, but I personally kind of wonder whether hypokalemia may be a more important risk than hyperkalemia in terms of the risk of events in this population, and then maybe we're overly fearful of at least mild to moderate hyperkalemia in the dialysis population where these patients are tolerized. But certainly people are pursuing that approach, and I didn't have time, but the ADAPT study, which I showed you, is sort of looking in a pilot manner at the use of that product to reduce hyperkalemia.
So somebody's asking in the chat, would finerenone be better than spironolactone in this population?
I think it's not clear. Certainly it causes hyperkalemia to roughly the same extent, but they've not been directly compared. I think that's obviously a study worth doing because there's a fairly significant cost differential, and at least in the dialysis population, we haven't seen very large levels of gynecomastia with spironolactone. Whether that study will ever be done, I think, is a different question, because certainly the makers of finerenone don't have an interest in making that comparison. But my guess is it's probably going to be similarly efficacious.
Another question here is GLP-1 rather than basal insulin for CVD protection and better glucose control without the risk of hypoglycemia.
Yeah, so I'm involved in a study of GLP-1 in CKD patients. I think the data so far is quite intriguing. There's certainly it hasn't been looked at in dialysis, so that's an important caveat. There's certainly suggestions of significant benefit in the CKD population, mostly so far for moderate CKD. I have a feeling in a year or two we will get an answer in the moderate to advanced CKD population. I think, SGLT2s lose efficacy for glycemic control as CKD progresses, but seem to retain cardiovascular benefit. My guess would be in the long run, we'll be thinking of a paradigm that includes GLP-1 for these patients, in addition to SGLT2, with the GLP-1, providing glycemic efficacy in addition to cardiovascular and potentially renal benefit. But we don't know the actual answer to that question yet.
Fantastic. Thomas, maybe we have 1 minute left. Can you make a final comment and maybe just tell people how they refer to the Site CV clinic and who you want to see in that clinic?
So first, thank you very much, David, for this comprehensive talk and about showing the future directions in the years to come. With respect to the Decide CV clinic, so it's a joint cardiometabolic clinic at McGill University. Patients with diabetes, GFR below 45, and atherosclerotic cardiovascular disease and or heart failure are seen simultaneously by a nephrologist, a cardiologist, and an endocrinologist. And we actually provide some evidence and help introduce complex treatments, and then we refer back the patients to the primary provider who continues the follow-up. So we're happy to see patients as needed. So
thank you so much. Sorry, I'm just going to interrupt you, but I'll let you stay on for a couple of minutes just because I do have to close out the official portion of this presentation. It's past 1 o'clock. A very special thank you to Dr. Charytan for joining us today from New York. Yes, you are in New York, right?
I am in New York, yes.
Just making sure. From New York. And thanks everyone for joining us this afternoon. And thank you for that wonderful presentation, a really terrific overview with lots of information there that's going to be very useful clinically. And thank you to the Division of Nephrology for this invitation today. And Thomas, I'll let you continue the conversation, but I will close the official portion of the Grand Rounds. Thank you so much. Thanks everyone. Bye-bye.
Thank you very much, Nadia. So, David, you brought up actually the question of SGLT2s in advanced renal disease. So, what do you think about using how these agents could work in this setting in hemodialysis? If you had to design a mechanistic trial, what would be your surrogate endpoint?
So we did design a mechanistic trial. And I think there's sort of two questions. One is, will they work in patients with really poor kidney function? And number two would be, will they work in patients, who are anuric, so really no kidney function? And the trial that I showed, just a schematic from earlier, our primary endpoint. So we're not looking at anuric patients. I think that's an important question, but we were looking at just with residual renal function, whether there are any effects on bioimpedance, in fluid overload. So that's really looking at as a primary endpoint on volume and as a diuretic. But blood pressure may still be impacted if they have some efficacy on even if it's not enough to reduce glycemia, it may still cause an increased urine output. The second way they may work is there seem to be lots of off-target effects. So there are physiologic and basic experimental data that suggests they may have an impact on autonomic function. There may be direct effects on cardiomyocytes and transport, at least into cells, not in the renal tubules necessarily, of various electrolytes, calcium handling and so forth. Now, all those are off target and not proven, but there's reason to at least investigate whether some of those off target effects may be important, and the data that glycemic lowering doesn't account in the mediation analysis for all of their benefits would suggest that some of those things may be operative and important in the cardiovascular benefits. And those would potentially be anticipated to work even in anuric
And you were probably the first to show that patients with advanced renal disease or dialysis are systematically excluded from all trials and all guideline-directed medical therapy. So how do you think we could improve this? I was thinking at some point of seeing CKD and end-stage kidney disease as a continuum where we wouldn't, let's say, censor the patient or make the patient ineligible once they start dialysis, because pathophysiologically, at least, you may argue that the cardiovascular context in a patient with a GFR of 10 who hasn't yet started and who starts for uremia, which is a little bit subjective, may be a little bit not that different from somebody who is an incident patient. I would like your comment on this.
Yeah, I mean, I think that's a good point. And in EMPA kidney, they, it's a kidney disease trial, so they have different reasons, but they, in fact, did not, they didn't censor the patients once they started dialysis, and nor did they require that they stop the investigational product. So we'll get some information there, and I think that approach is probably something that can be extended to other trials of other areas, going forward. Obviously, something that's kidney metabolized and might be dangerous as GFR declines, that approach might need modification. I think just working with funders and pharma to not exclude patients with CKD, just by design, unless there's a really good reason for it, is another approach. I don't think that'll ever get us to the point of having lots of randomized data on dialysis patients, right? Just because, they're not that common, so even if you don't explicitly exclude them, which perhaps we shouldn't, it's unlikely that in a large cardiovascular study, even if they're not excluded, that you're going to enroll lots of those patients. I think, the other approach obviously is that we need to get funders interested, in looking at this population in particular. I mean, there's certainly been a lot of studies of patients with diabetes. It's a bigger, that are specifically targeting cardiovascular risk in patients with diabetes. But there have been many fewer targeting patients with, on dialysis or with advanced CKD and, cardiovascular risk. And so that, I think, has to be also, a part of the approach to improving our evidence base.
Thank you very much for your comments and suggestions. So I think if there are no other questions in the audience, I would like once more to thank you for talking to us about your work on this field and showing us the interesting discoveries that may lie ahead in the years to come, and wish you an excellent day.
All right. You too. Thank you for the invite.
Thank you. Bye-bye.